Hearty good afternoon and welcome to a session on failed IVF. Today we are glad to have Dr. Pratibha Pasari among us today to help us understand and explore this topic. And the more we try to know about what causes failures in IVF, or more in this case, will help us understand this and tackle it. So, Doctor, you have the stage.
Thank you so much. A very good afternoon to all. It is said that difficult roads leads to beautiful destinations. So is the journey of IVF. Though difficult, but it will lead to a beautiful destination called pregnancy and motherhood. So friends, here I am today speaking on a very sensitive topic, that is failed IVF. We all know what a stress a patient goes through during her IVF cycle, both physically, mentally, and even financially. So when this cycle fails, it is a moment of despair, not only to the patient but also to us clinicians who are treating those patients. Even though we do all kind of evaluation before we are taking the patient, but sometimes the cycle fails. That's why the success rate is around 40 to 50% average success rate. But in good centers, we can give as good as 60 to 70% success rates and even 80%. So there are some factors which may be known because which led to the failure of the cycle, and there are other factors which are not known for which the cycle failed. So let us see what are the factors which makes the cycle fail. So for a pregnancy, we need good eggs, good sperm, which make a good embryo, and this embryo is then put inside the uterus. That is the implantation. We will call it embryo transfer. So we need a good uterus and a good endometrium for that. So if there is any problem in any of these factors, that may lead to the failure. And sometimes when there is no factor, that may also lead to failure. So first let us see what may be the problem with the eggs. So the eggs, the number and quality of the eggs is totally dependent on the age of the patient. As the age advances, the quality and quantity of the eggs are deteriorated. Say till 20 to 30 years of age, the quality and quantity is good. When it reaches 35 years, the quality and quantity both decreases. And after 35 years, it decreases rapidly to become almost nil at about 40 years of age. So a good reproductive potential is at 20 to 30 years of age. So when a patient has come to us with, say, advanced age like 35 to 38 years of age, and she is undergoing IVF with us, and she insisted if her ovarian reserve is not good, but she has insisted us that she will proceed with her own eggs. We try all the methods to improve the quality of her eggs. We cannot increase the number of eggs. There are medicines which can improve the quality of the eggs, but the number of eggs cannot be increased. So after doing that, we take the patient, we do the ICSI, that is the fertilization, we make the embryo. And with the status of the embryo, we know whether the fertilization was good. Say we grow the embryo till for 5 days, and this is called blastocyst. So if with those eggs we are able to make good blastocyst, then maybe they will give a good pregnancy. Maybe they will not give a good pregnancy. I will tell you why later. In my previous videos also I've explained how eggs are dependent on age. So as I've told you now that as the age advances, the quality and quantity decreases. So the age and eggs are inversely proportional to each other. So in this case, what we will do, suppose patient had gone with her own eggs, she did not form good embryos, and even if she had made good embryos, they did not implant. The cycle failed. Maybe the embryo quality was not good. Maybe the quality of the egg was not good. So in this case, we have two options. Either we can go for the genetic testing of the embryos, that is the PGTA, or we can offer donor eggs to the patient if her ovarian reserve is too low. So the eggs can be taken care of in this way. Next, we come to the sperms. The quality of the sperm we can know by a simple semen analysis, which will tell us about the count, the motility, the morphology of the sperm. So, seeing that, we can know whether the quality is good or not. If we see that there are certain parameters are not up to the mark, so we give medicines to improve them. And after we repeat the semen analysis again to see the progress in the improvement of the quality. So if it is improved, we take them for IVF. So we try to improve the quality and then take for the IVF. So again, we if it makes a good embryo, if it makes a good blastocyst, so we think that the quality was improved and they have made a good blastocyst. But again, the quality can only be known if we do the genetic testing of the embryo. So in this case, if the sperm quality was very not very good, so we can go for one test called the DFI, DNA fragmentation index. If it was not done earlier, in this time, in the next attempt, we can do this DFI. If the DFI is not good, say if it is more than 15%, then we should not go with the self sperm. Then we have to go with the donor sperms. So this is all about sperms. Now we come to the embryo. So when we fertilize the egg and the sperm in the laboratory by the method of ICSI, nowadays we do ICSI, we don't this is an advanced form of IVF. So in ICSI, what we do is we take an egg under the microscope, we take a sperm, we insert the sperm inside the egg, and this is how a fertilization is done. And we grow it for 5 days, and this technique is called blastocyst culture. Now, many centers which do not have this technique, this blastocyst culture, what do? They do is they transfer day 3 embryo. So it is at this stage, it is at the blastocyst stage that the eggs, that the embryo is implanted on the lining of the uterus. So if the embryo is not grown up to the blastocyst stage, so maybe it has the potential to grow, it may not have the potential to grow up to the blastocyst stage. So the success rate is less when a day 3 embryo is transferred. And the success is more when a blastocyst is transferred. So we grow the embryo till the blastocyst stage. Now next technique comes freezing them. So when this blastocyst is made, what we do is we then freeze these embryos. Why this freezing is needed? This freezing is needed because in the female body, we had given hormonal injections to make these eggs, to develop the eggs. So there is an imbalance in the body, hormonal imbalance in the body right now. So we go for one cycle of menstruation for these patients, and then we transfer this embryo inside the uterus. So this is called frozen embryo transfer. So in the previous cycle, wherever have you done, so if they have gone for fresh embryo transfer or an embryo transfer with a day 3 embryo, the success will be less. If you go with day 5 or the blastocyst embryo transfer, the success will be more in this case. So if we had gone for day 3 transfer, in this cycle we have to go for day 5 blastocyst transfer. Then again, if there is one technique called laser assisted hatching. So what happens, the embryo which is made, the covering of the embryo, it may be hard. If it is hard, the embryo may not hatch out of the shell to get implanted into the uterus. So what will happen? The embryo, we have transferred the embryo, but the embryo will not get implanted into the uterus. So in this case, what we have to do is we have to go for laser assisted hatching. There is a technology where we give laser rays, laser shot to the shell of the embryo so that it gets sliced off and the embryo hatches easily to get implanted on the lining of the uterus. So if these techniques, the laser assisted hatching and the blastocyst culture, was not used in the previous cycles, we can use in these cycles. Next again, we have seen about the eggs, we have seen about the sperms, we have known about the embryo, Now comes the uterus and the endometrium, where we are going to transfer this embryo. So the uterus, we have to look for any pathology in the uterus, like any kind of tumor, that is we call fibroids or adenomyosis. So if there is fibroid, like if you have fibroid, so it is taken care of prior to your IVF treatment. But what happens? There may be some fibroid which the clinician may feel that it is not necessary to remove them. So in this cycle, we have to reanalyze them, that whether it is really necessary to remove them or not. Then again, if there is adenomyosis, if there is swelling in the uterus, which we call as adenomyosis, if it was not taken care of before, then we can take care of it in this cycle. And there may be certain polyps which might have been missed. Polyp is the kind of this extension of the endometrium lining inside the uterine cavity. So if it was there, or if it had grown newly, then if we can see after the failure, after when we are doing ultrasound, we see that there is a polyp, we need to take care of that. So this is about uterus. Now there is the lining of the uterus where the embryo is implanted. This is called endometrium. Endometrium also plays a very important role. So this endometrium, we have to assess the thickness of the endometrium and the quality of the endometrium. So in many cases, the endometrium is thin. It does not grow up to the optimum level, which is around we should be more than 7 mm. So if there are various procedures which we do to grow the endometrium. So if the endometrium has not grown up to an optimum level, we have to do another procedure. This is called PRP, where we insert a platelet of the patient inside the uterine cavity, which really helps to build up the endometrium. So if this was not done in the previous cycle, if the endometrium was thin, if PRP was not done, so we can consider PRP in this cycle. And we can give more drugs to improve the lining of the endometrium, the thickness of the endometrium. Then again, by the side of the uterus, there are fallopian tubes. If there is hydrosalpinx, if there is collection in the fallopian tubes, watery collection in the fallopian tubes, we call it hydrosalpinx. So if there was hydrosalpinx before, and the clinician felt if it was a terminal hydrosalpinx, like on the ends of the tubes, a small size hydrosalpinx, which the clinician thought that it was not necessary to remove. So in this cycle, we are to remove this hydrosalpinx. We have to take care of this hydrosalpinx and then proceed in this cycle. So we have taken care of the eggs, the sperm, the embryo, the uterus, and now the endometrium, and again the tubes. So when a cycle fails, it is really a challenge for us also, because when we have done everything, and again if the cycle has failed, so we have to really check what is the actual reason for it. So we take the patient for sonography again, if there was anything which was missed. After all, we are all humans. Again, we do the hysteroscopy of the patient. Hysteroscopy is that we go with the help of a camera. We see inside the uterus, that is the cavity inside the uterus, which is called uterine cavity. That is the endometrium lining of the uterus. If there was anything which was missed, so it will be taken care of in this cycle. And other tests which may be necessary to do in this cycle, we do them and then we proceed ahead. So these are few things, few discussions which is really necessary when we are taking care of a failed IVF case. So any of you, if you have gone through this, you may ask any question to me so that I can help you in planning your cycles ahead. Any questions? Okay, if there are any questions, you can connect with me at Polo Fertility Guwahati. We'll surely get back to you. Thank you so much. I'm leaving the show.